But this is a very difficult decision to take, especially when you are holding a startup, because if you fail on the first one, it was be the end of the story.
Yes.
So I was more or less expecting a good patient, to start thinking about implanting the valve for the first time. But this is not at all what happened. When you are talking about your innovation, the first reaction is always negative.
No, yeah.
Because they think if it could exist, it would already be done, And many people think if it could be done, I would be the one doing it. Tens of thousands of people have been treated by balloon aortic valvuloplasty around the world during 5-6 years. I went to the room, the patient room, and discussed with him for explaining that he could be the next sheep. And I can tell you that finding the right words for that was very difficult.
Tricky.
I didn't sleep of the whole night. I was called to India to teach the people and to speak about balloon aortic valvuloplasty. And I fell in love with India, really. These are the right words, and with the people and with the country. And I think interventional cardiology really needs women. I really realized that at the very beginning of my career, because I have been really supporting women in my department when I was chief of department. Yeah. There is a misogyny, in the misogyne aspect of the problem. When I asked Anna China, for example, she was a resident. When I said, if you want to do the cardiac catheterization, you can. I was very much criticized for that because she was a woman.
Really? By your colleagues or by?
Yes, by my male colleagues.
Once every few decades, in any field, be it healthcare, business, technology, there comes along what I call a positive disruptor, somebody who disrupts the status quo in any field in order to introduce a change or an innovation for the betterment of that field. Professor Alain Cribier is one such disruptor, one such game changer in the field of cardiology. Amongst numerous achievements and innovations, Professor Alain Cribier remains best known worldwide for being the inventor, the pioneer, and the implanter of the very first TAVI valve in the world, now more than 20 years ago, which was introduced in order to treat inoperable patients suffering from severe aortic stenosis, a life-threatening condition where the heart valve is critically narrow. And that was a procedure which was done minimally invasive as a keyhole procedure, which was a first in the world. Now, 21 years later, worldwide, there have been more than 1.5 million patients treated across 80 countries, saving countless lives. I am beyond thrilled to be able to introduce to you on this very first podcast, Heart Rhythm, this wonderful human being, this living legend, pioneer, mentor, and a hero to so many of us cardiologists, Professor Alain Cribier. Thank you so much, sir, for welcoming me here in Rouen, in this beautiful training center. How are you?
Yes, I'm absolutely fine, and I am very happy to be with you for this discussion about TAVI, and it's a real pleasure. You already came several times at the Medical Training Center, so you belong to the family, actually.
I'm part of the family.
It's a real pleasure for me to be with you.
I'm thrilled to know that. So you've been really, really busy this year, last year, with several engagements. You've been traveling all over the world. You've been invited as a speaker. And more recently, you've been awarded numerous very prestigious awards and prizes. So there was last year, the American College of Cardiology awarded you the Presidential Note, the Presidential Mention. There was in Seoul, very recently in South Korea, you won the Masters of the Masters Award. And I think last month in France, you were newly elected as an honoris causa member of the National Faculty of Medicine in France, which is Academy of France, which is one of the highest distinctions in medicine, really. How does it feel to be there.
Well, actually, I feel very much honored, but this proves that this technology that I have developed is very well received, and there is a very strong commitment of all the interventional cardiologists and even the surgeons now to perform it, and there is a kind of recognition, of the value of this technology. So I'm very proud, but I must say that. Each time when I receive this kind of award, which are very honorific, I associate all my teams and many people who have been with me. You cannot do an innovation by yourself. You have to be helped by people that believed in your ideas and supporting you all the time. And so I associate all these people in these awards.
That's wonderful. And I mean, I can gauge for that. I've had the pleasure to meet some of your team members. It's really like a close-knit family that's developed a very strong bond over these last few years with the development of... It's wonderful to see, and it's very rare, I think, personally.
Yes, absolutely. Yeah, it's a family, and I am working with people since the very beginning. For the last 30 years, I have been working with almost the same people, and especially Professor Hélène Elchaninov, who has been my right arm, in this adventure since the very beginning, and many other, that I am still working with them now, and always supporting and being on my side, encouraging, and we have been sharing many
experiences,
many difficulties, on this long road, to achieve this technology.
And we'll be talking about those in a moment. Yeah. So the whole world celebrated the 20 years of TAVI on a stupendous scale last year. I was lucky enough to be invited, fortunate enough to come to Rouen for the 20-year celebration of the TAVI, where people, physicians, researchers flew from all over the world to share their experiences and their happiness, their genuine joy at the 20 years of TAVI. The mayor was there as well. It's absolutely gorgeous celebration and ceremony. And I remember sitting there and thinking, I was watching all those, there were some emotional sharings as well of the experiences of different of your team members and of yourself. I remember thinking the whole seed that started this whole beautiful journey of TAVI was that one brilliant idea that you had more than 20 years ago. Now, there is a fine line between just having an idea, which is creativity, which a lot of people have, and crossing that line in order to implement the change, bring action, and develop the idea, which is your innovation. The next question comes in two parts, if you don't mind. The first part is, what motivated you 20 years ago to implement your idea for a TAVI and to keep you going as well? Number two, did you foresee the huge impact that your device, your procedure would have all over the world?
Well, short questions that would deserve a long answer.
Yes,
so I will try to make it short. First of all, my chance has been to be trained in the United States in a remarkable team of very world-renowned cardiologists, William Ganz and Jeremy Swan Ganz.
The famous duo.
And so I spent 1 year and a half with them in their lab, and they transmitted to me the virus of research and high-level innovation. And they taught me how to believe that I was strong enough, to solve the clinical need myself. So it was very presumptuous. But when I came back from United States, I came back to Rouen, and I was very much interested in selecting the most important clinical needs that were not fit at that time, and trying to find solutions to improve the patients. Mm-hmm. And it was absolutely the case with aortic stenosis. So not only aortic stenosis, we had also some other valvulopathy, like mitral stenosis, for example. I have been also working on that. Mm-hmm. But aortic stenosis was a very crucial need. Because at that time, it was in the early 80s, mm-hmm. most of the patients, more than 50% of patients were turned down by the surgeons and the anesthesiologists for aortic valve replacement. Because at that time, age per se, more than 70 years, was considered a contraindication for thoracic surgery. So I had in Rouen a number of patients who came with symptomatic aortic stenosis, in general, all patients. And most of them were declined for surgery. And we know that the spontaneous prognosis of this disease, if it is not treated by valve replacement, is horrible, with 80% deaths within 2 years. So I was observing the patients coming back to the department and dying after several hospitalizations, and we could not do anything for them. So I started thinking that maybe we could find an alternative treatment, less invasive than cardiac surgery, to at least improve them. I was not thinking about prolonging the life, but at least relieving the symptoms and, if possible, making their life better. And this is why I started thinking about balloon aortic valvuloplasty, because I was performing balloon dilatation of the pulmonary valve, in children and young patients. And so I had the technology in my hands. And so I started thinking that maybe, we could use the same technology to at least increase the orifice area of the aortic stenosis and maybe do something good for the patient. But, this was the idea. And it was difficult to have this technology accepted by my director of the Department of Cardiology at that time, Professor Bristol-Tack, who was a guy wonderful and very open to research and innovation. But this, inflating a balloon inside the calcific aortic stenosis was considered absolutely unfeasible and insane. So several times, I came to him and I said, maybe could we start to do something like this, to at least relieve the symptoms? Maybe something could happen, good for the patient. And I received a patient, the very first patient, who was a 72-year-old woman, was really dying. She couldn't do anything. She was highly symptomatic, and she came several times, and she was declined for valve replacement. And I said to my boss, why don't we start on her? 3 times, and he said that each time he said, no, you are crazy, it won't work, you will kill the patient on the table.
So he declined 3 times.
So I used the opportunity of having him in vacation outside. And for the 4th time, I called him and I said, let me do it because she is coming back again and she's really dying. And he said, you are insisting too much. So if you want to try, but the chance of success will be 0. And so we did the first balloon aortic valvuloplasty, and it was a big success. It was nothing happened. The patient was doing very well. It was percutaneous approach, retrograde from femoral artery, and we inflated the balloon. Nothing happened. And the gradient decreased, and the patient was absolutely relieved of all symptoms. Gosh. And during 2 years, she had a very, very normal life. So it was a big bang. It was a big bang.
Wow.
And this was actually the beginning of the story. This was in September 85, so it's a long time ago. It's more than 4 years ago. And I will always remember this first case because then I realized that something could be done using less invasive techniques than surgery, at least to improve the patients. So this is how to start with the idea, trying to improve, doing something, and going to practice. This was the first step.
So you were driven, one can say, by really your passion to help patients.
Yes, well, absolutely.
It boils down to
this. I
this.
could not admit, to have all these patients coming back and dying, without any possibility. There is absolutely no medical treatment for this disease, and so. So I started doing this, and you cannot imagine, because you were not there, the success that I met, after publication of the first series of patients with balloon aortic valvuloplasty. We received in Rouen hundreds of people coming from all over the world, to learn the technique. It was the first experience, of this widespread evolution of this the technology, which was very well accepted because it was very simple to do, and all the people, they were observing the same kind of results, relief of symptoms.
So
this was the first idea. I'm sorry, I'm a little long to answer, but it's difficult to make it shorter because tens of thousands of people have been treated by balloon aortic valvuloplasty around the world during 5-6 years. And to give you an example, we have more than 1,500 papers published on the topic and many big registry, including thousands of patients. But unfortunately, and this is something that the people who want to innovate has to know, sometimes a success can
be short-lasting.
Can be not that short, but can change and can become a failure. Because after 5 years, it was absolutely obvious that there was no long-term results. There was a kind of early restenosis, and I started thinking about this 2 years after the first case of balloon aortic valvuloplasty, when I saw people coming back, I had to redo the procedure again, so I was disappointed, and I thought that something could be done. When we have to face such kind of failure after the big success, world success, you have two way of being. You can say, well, it's a failure, I quit, I leave, and it's finished. Or you can try to find a solution. And in my mind, I really wanted to find a solution. So in '87, during one of the meetings that we had on balloon aortic valvuloplasty, I announced for the first time that my goal was to implant an aortic valve, an artificial valve, using interventional cardiology, minimally invasive, from the femoral artery, using regular cardiac catheterization procedures under local anesthesia, because general anesthesia was one of the big reasons for not operating a patient.
Turning down a patient.
So I wanted to make it simple. And today, when I see the result of that, it's exactly what I had in mind at that time. Doing something very simple, like a stent-like procedure. And so I started with this idea, but it was a long road to achieve
long road.
it.
We'll come to that. Yeah. So the next step, obviously, was this long journey towards TAVI. We will discuss the actual first TAVI patient in the context, because I remember hearing you tell the story of that first patient who was implanted with the first TAVI in the world. And I don't know if you realized, but the atmosphere was electric, and I had goosebumps. It was very emotional. It was almost like we were there with you. But before we go on to that exciting part, obviously Rome was not built in a day.
No.
So from that time where you had in place that balloon technique, which unfortunately didn't last beyond years, what was the kind of journey? If you can summarize, I just want to say some of our audience is not medical, so maybe in simpler language, if possible, where possible, just to explain to us that kind of journey, the milestones.
Yes, well, I can try to summarize that, because it's a long story. It lasted maybe 8 years.
Wow.
To develop TAVI. And so what I would like to say to the young people, and if it can be inspiring to them,
Absolutely.
When you want to develop a new technology, you have to believe in your idea. You have to face a number of obstacles. You will be criticized sometimes very toughly, and you have to face these criticisms, and don't give up, never give up. There is a key word in innovations, perseverance.
Yeah.
If you believe in your idea, you have to persevere in spite of many, many obstacles on your way. So this is an advice. Don't be discouraged, never. Keep going,
keep moving. Yeah.
Well, actually, there were several things, during this 8 years period. First of all, I have to think about a device to be placed inside the aortic valve.
Yes.
So I first started thinking about a kind of spring, but it was a little crazy. And then I moved to a stented valve, because at the same period of time, there was a launch of a peripheral stent by Johnson & Johnson, the Palmas stent, which was used for treating iliac and big vessels. So I said, well, if we can inflate a balloon in an aortic valve, a calcific aortic valve, pushing away the calcium with a circular opening of the balloon, maybe we can use this opportunity to place a stent. If the stent is very resistant to compression, if the stent can be opened circular, maybe we can think about implanting a valve inside the stent and making a complex stented valve that could be placed by balloon inflation, as we do for balloon aortic valvuloplasty, and at the same time, as we do now, we stent, coronary stent after balloon angioplasty.
Absolutely.
It's some kind of thinking, except that we had to have a valve inside the stent, which was a little different. And so I made some drawings. I discussed for the first time with surgeons, to ask them their opinion, and they were absolutely discouraging. They said that I was totally crazy. It was absolutely impossible, to just think about implanting a valve inside a calcific aortic valve without removing the native valve, which is a piece of a block of calcium. That never we could cross the valve, the native valve with the device. Never we would be able to inflate the balloon completely. And if ever it was working, it would be very transient result with a number of complications on the way, because the location of the aortic valve, for those who don't know that, is very special, because just above are the ostia of the coronary arteries, a few millimeters above. Just below the aortic valve is the insertion of another valve, the mitral valve. And also below the aortic valve, there is also the His bundle, coming from the interventricular septum, with all the conduction system of the heart, the electricity, making possible for the heart to contract. So they were saying, if you put a valve, on a beating heart, if you can cross the valve, inflate the valve, you will destroy the coronary arteries, mitral valve, the His bundle, you will kill the patient on table, the valve will embolize, and you will have endocarditis because it will get infected, and well, they had a listing of complications, and they were very negative. So when you face this kind of remarks, always negative, you have to try to prove that you are right, and you have to control if they are right. These people will say that it's impossible. So there was a very important step in this innovation, which was an autopsy study that we did with Hélène Elchaninov, my colleague, and who is now chief of the Department of Cardiology, and with another guy. And we went to the autopsy lab, because at that time we could obtain autopsy for all the patients who died. It was very easy. And so we used this opportunity to implant stent inside the heart of the patients who died of aortic stenosis. So we had all forms of all types of aortic stenosis, very calcific, less calcific, massively calcified, and so on. And the result of that was absolutely unbelievable. In each patient, I was able to inflate the balloon and inflate the stent inside the valve without any problem. Each time the stent was opening circular, fully open. Never the stent was squeezed, by the compression of the calcium. Never. Already. And it was not a specific stent. It was a Palmas stent. It was a regular stent. So this was the first observation that we had, and we were shocked. And
so that was an encouragement to you.
It was unbelievable, because the surgeon said that it was impossible to make it. Also, we could determine the dimension of the stent that could have enough room to be inflated in place without occluding the coronary arteries, the mitral valve, and crushing the septum. So between 15 and 17 millimeters of height of the stent that we cut, it was working absolutely well, and never the coronary artery were blocked, never the mitral valve was destroyed. So the conclusion of that, after 16 cases that we did here, was that actually the concept of valvular stenting in aortic stenosis is fine. It works, in opposition to what the surgeon said. Of course, there is a long way, to demonstrate that it's feasible to implant this kind of device in a man on a beating heart, because, you can imagine that to precisely implant the stent where it has to be done. And also we had to make to build a valvular structure inside the stent to connect the valvular structure to the stent. And this composed stent and valve had to be compressed over a balloon to be introduced through the femoral artery and delivered by balloon inflation without destroying the struts of the stent and the artificial valve inside the valvular structure. So it was
a lot of conditions had to be right.
So actually, I did some drawings. I filed a patent in a European patent with my drawings. You know. And I have been spending 5 years to try to get some sponsorship, to develop this model of valve. Yeah. I have been contacting all the biomedical companies potentially interested in that, including Edwards Life Sciences, Medtronic, Boston Scientific, Johnson & Johnson. They all said that it was absolutely crazy. I received the message that it was the most stupid idea ever proposed. And these experts, who are the cardiac surgeon, of course, because we are talking about the aortic valve, so the experts of the companies were cardiac surgeons, they say that you must very fast forget about this project. It's absolutely stupid. So it was a complete failure. So as I said, perseverance, don't be discouraged, keep going. But during 5 years, receiving this negative answer from a company was really difficult. Tough.
Yeah.
And sometimes I was a little discouraged, because I didn't see any possible solution. And the miracle occurred. And when you are developing some innovative technology, also you have to have the chance on your side sometimes. It's very important. So I met on my way. It was in Paris during a EuroPCR meeting. I met a guy who was engineer in Johnson & Johnson, Stan Rabinovich. And again, I discussed with him, about this idea, but I knew the answer. I was very pessimistic. Yeah. And very amazingly, the guy said, well, it's not a bad idea. Maybe we could do something and help you. And I will discuss with another of my colleagues, Stan Rowe, another engineer working in Johnson & Johnson. And we will see his reaction, And Stan Rowe was very positive,
Wow.
So this was a miracle, really. And so they started thinking about the possibility, of making the valve at Johnson & Johnson.
Yeah.
I signed a research program with Johnson & Johnson, who initially said that they were not interested, but because of their influence, they have been trained in making stent by making the Palmach stent, the Palmach Schatz stent for the coronary arteries. So they had some experience of stent, and so they were open-minded. And so nothing happened in Johnson & Johnson. After 2 years, nothing happened. They didn't make any progress. They didn't work on the device, the prototype. I got nothing. So finally, they talked with the medical director of Johnson & Johnson, who was Martin Leon. Martin Leon, who is a big name in the United States. And Martin Leon said, I am interested in the project, even though the chance of success is minimal, maybe less than 20%, but we can try to do something. And so finally, with these two engineers and Martin Leon and myself, we created a startup. So this is also something that the people who innovate in medicine have to know. If they have no positive response for the biomedical companies, if they cannot get any money, if it doesn't work, they may start thinking about making a startup. And so, because a startup is fully dedicated to this project, so it's very efficient. So we created a startup that we called Percutaneous Valve Technology.
PVT.
It was in 1999, so already a long time after the first balloon aortic valvuloplasty. Yeah. Percutaneous Valve Technology was a startup that was located in New Jersey, in the United States, with a very small amount of money. And at least we we had the support of Martin Leon, who knew a number of people in the world, and especially in Israel. And so we had the opportunity of contacting a small company in Israel during a meeting in Tel Aviv. And a company which was not at all specialized in medicine. They were making other things, absolutely. But they decided to launch some device, some medical device. They were open to that because they had hired an engineer from Medtronic, Asaf Bash, who had been also working on stent. And so they said, well, we have these engineers, we want to start medical innovation. We should start with that. And so they were our first partner and investor and engineering company, to make the prototype. So I received the engineer in Rouen. I showed him what was balloon aortic valvuloplasty. He was very impressed because the reaction, the consequences of balloon aortic valvuloplasty were very dramatic for the patient. He was improving on the table. So he was very impressed. And he went back to Israel and started working on the device. And after many attempts of making some prototypes, so I was going back and forth to Israel. They were going to war. After only a few months, he came with a prototype which was exactly what I had in mind in my patent. It was absolutely perfect. It was a stainless steel stent, which was laser cut, from a tube, 23 millimeter in diameter, because these were the dimensions that I gave to them. Yeah. And they managed to suture inside the stent a 3-leaflet valve, which was made of polymer. And I don't know how they made that. It was the challenge was so high. They made the valve. They could suture it inside, and they made a number of laboratories tests showing that the valve could be compressed and redilated without any deterioration. So it was unbelievable. So I was extremely excited with this, and.
You went back to your director.
It was unbelievable. So we had several meetings, because it's a long road again. But they made all the tests for making the valve to prove that the stent was working. The leaflet structures was working well. Okay. And they did a lot of bench testing, to test the durability of this valve, which already crossed 5 years in the bench. Yeah. And so immediately, we started with Elena Chalinov, again her, in Paris, an animal experiment on the sheep model.
Sheep, yes.
And we implanted this device in more than 100 animals at various places, in the aorta, in the pulmonary artery, in the native valve, and so on. The very first case that we did was implanting this valve in the what so-called orthotopic position. It means inside the native valve of the sheep, and it was a big success. So the first sheep,
okay.
And it was just before the TCT meeting in the United States. Yep. So I took the videos, and Martin Leon was directing the TCT meeting, gave me a spot, to present the data.
Yeah.
And the reaction of people was very positive, and so we received a lot of investments, because the money is a crucial point,
yes,
if you want to develop something like that. So private investors came, and so we could continue the experiment. And we did that during 2 years. And it was very difficult in the sheep to implant in the orthotopic position because the coronary arteries are closer, the mitral valve is closer, it's not the same anatomy. So we were not very successful in doing that again, orthotopic position. Okay. But we implanted the valve at different places. And also we developed, with Hélène, a special model that allowed us to implant the valve in the descending aorta after creation of aortic insufficiency by partial destruction of the native valve of the sheep by a biotome, which was crucial because if you don't do that, you cannot implant the valve in the descending aorta because after 1 hour it's dead, because there is not enough gradient across the valve. So it worked very well, and so we could follow the recommendation of the Food and Drug Administration in the United States to do 10 consecutive sheep with implantation in the descending aorta. without any destruction, and with the proof on transesophageal echo that the valve was perfectly working after 5 months. So we had this long-term feasibility study in the sheep, which was absolutely crucial. So this was the end of the experiment. And so again, we did more than 100 implantation, and we used this opportunity to develop all the technical aspects of the transcatheter valve implantation in human, for the delivery system, the balloon use, the way of selecting the size of valve and so on. Everything was in our hands. And then we had to think about the possibility of moving to human. But this is a very difficult decision to take, especially when you are holding a startup, because if you fail on the first one, it was be the end of the story. So I was more or less expecting a good patient, to start thinking about implanting the valve for the first time. But this is not at all what happened.
I know the story, but I will let you unfurl the story for our audience.
You want me to talk about the first patient?
That first patient, yes.
Well, actually, it was unbelievable, because one day we received a patient from the north of France who was coming from balloon aortic valvuloplasty in a patient in imminent death. He had several episodes of cardiac arrest. He was only 57 years of age, very young. And he had a very severe aortic stenosis on the bicuspid valve.
Gosh.
And he had an ejection fraction of 12%. It means that the heart was hardly beating, and he was really dying. So he came to us not for a valve, because the valve did not exist still, but he came for balloon aortic valvuloplasty using the transseptal approach, because the femoral arteries were occluded, and he had a recent occlusion of a double bypass from the aorta to the iliac vessels. So he had no possibility of being treated by the femoral artery. So we had to do a transseptal balloon aortic valvuloplasty, and we had that in hand very well in Rouen, because we had several patients like this, but not that severely diseased. So I did that on the day of his arrival, and it was not a success, because during the time we were doing this, he had several episodes of cardiac arrest. I had to shorten the procedure. So we had some kind of little improvement, but 2 days later he was back in shock, in cardiogenic shock. And so he was dying, really dying. And so 57 years of age, could I think, implanting a first valve in this patient who had no femoral approach, using the transseptal approach, the transseptal route, which was so highly challenging. So, but if we didn't try that as a last resort, the patients will die within hours or days. So I called my friends in the United States, Martin Leon and the engineers, and I said, I have this patient, maybe we could use it for the first time for an attempt of implanting the valve, but the chance of success is less than 10%, because I have to do it using the transseptal route. And so their first reaction was not very positive, because the consequences of a failure would have been really bad. But finally, after an exchange of, I have the mails, I could show that to you, pages of mail. They said, okay, because you can do it because for ethical reasons, because you can save his life. So I went to the ethical committee of my hospital to say that we have a new technology that could maybe be tested in this patient, but the chance of success is very poor. But if we don't do anything, the patients will die. And they said yes. Okay. So one day after, I went to the room, the patient room, and discussed with him for explaining that he could be the next sheep. And I can tell you that finding the right words for that was very difficult. I didn't sleep of the whole night, saying, well, how can I explain to the patient that he will be the next sheep? And so I entered the room, and with some hesitation, I started saying, we may have a new technology that might work, and so on. And there was in the room his son-in-law, who said, don't spend your time, to explain this. We are very aware of what is a first-in-man case, because I am myself a man who received the first laser angioplasty in Germany in the world. Yes,
Incredible.
It was the family of the patient.
It's a family of first.
This kind of chance and miracle. So he said, don't waste your time. We want you to try. And the patient was, please do something for me and so on. So we put it on the table, and I must say that it was the most stressful situation that I met in my life, and I was doing this with Hélène Elchaninov, with whom I did all the cases in the ship, and another fellow, Christophe Tron, who was an interventional cardiologist, very experienced. And we started doing the transeptal catheterization, but we had to improvise, step by step, because it had never been done, and especially using a transeptal approach. So I didn't know if the valve would be able to cross the interarterial septum. We had to dilate the septum after transeptal catheterization. I managed, to advance the guide wire from the femoral vein to the contralateral femoral artery, because there was room enough for a guide wire to exit from the femoral artery.
Okay.
And so we had a kind of rail, and I advanced the crimped valve as we did in the ship, exactly as we did in the ship. And there was some blockage at the level of the septum, but we could push it further. Then we had to turn inside the left ventricle, do a U-turn, and the patient had the floating thrombus in the left ventricle. So I was very stressed. We will dislodge the thrombus, and the stroke will be there, and so on. Nothing happened. So we made this U-turn in the ventricle and reached the aortic valve. And then there was a very unbelievable moment, where the placement of the valve, where to place it exactly, And also the heart was beating. But fortunately, at that time, the patient had a cardiac standstill. He started the ventricular tachycardia, and so the heart was almost not beating at all. So I just placed the valve in the middle of a calcium that I could see on the screen, and very, very rapidly opened the valve. So it was the most stressful thing that I did again in my life. I could see the eyes of Hélène like this. And the valve was delivered in good place. And immediately I removed the balloon very fast, and what happened was again a miracle. Immediately, the patient who had absolutely no more aortic pressure, he was in cardiac arrest, if I can say. We could see the aortic pressure moving up to normal, to upper the regular level that he had before, so I could even interrupt the vasopressors at that time. The patient was living, he was smiling. We could observe on the table, the change in his face's color, from black to brown to white to pink on the table, in the minutes. With Hélène, we had decided that if the patient survived half an hour, it would be a success. We were watching the clock, on the wall, and we reached half an hour, and the patient was very well. We did echo and so on. 1 hour later, the patient was back in his room, and immediately we went with a bottle of champagne, and he was able to drink champagne with us. He was sitting up, and speaking normally. It was like a clear-cut resuscitation.
That's
so
incredible.
Then I realized that I had in my hands
there's something to this
way that could maybe save life of people. And 1 day later, he was able to answer the question of journalists and all the TV channels. We came into his room, to take his interviews. He was doing very, very well. And so the case was published within a couple of weeks, in Circulation. I was amazed also of the acceptance of Circulation to publish this case. And this was a second bomb effect in the medical community, I can tell you. It was just unbelievable. Unfortunately for this patient, the follow-up was not that good, because 4 months later, we had to do a leg amputation, because he had the ischemia of the leg before coming.
So
it was worsening. There was absolutely nothing to do to improve him. So we had to go to amputation, and this was too much. So unfortunately, he did not survive the leg amputation after 4 months. But during that time, the left ventricular function was improved a little. He had no more. I didn't tell you that he had no myocardial contractility on stress echo before before coming. So we knew that he had also a cardiomyopathy. But he was symptomatically very much improved. And so this patient, as I said, was published in Circulation, a big success, and it was received with enthusiasm by the medical community and with the fury of the cardiac surgeons. We said, him again, coming back.
They were thinking maybe you're taking some of their work away.
Coming with the percutaneous valve. So they did not believe, they did not believe that it would work anymore. They said he had a very high chance. It was a miracle, but he won't be able to do it again. Well, then, I had to convince the health authority in France to let me do a series of patients. And again, I had the surgical experts against me, who said, first of all, they said, no way, just forget it. And then they said, okay, you can do it, but only in patients like the first one, imminent death, survival of less than 2 weeks, spontaneous survival. Of course, functional class 4, not operable at all, declined by several
really
surgeons.
High-risk patients.
The worst patient that you can imagine. And almost 1 year after the first case, we started a series, and we did 38 patients coming from everywhere in France or from abroad, in such bad shape that many of them died during the transportation to Rouen. Some of them died at the time they were entering into the intensive care unit, at the time of at the first contact. And but also they said you have to do it transeptally, using a transeptal approach.
Because you'd done the first one.
So we had 75% of success in 38 patients, the first series of patients. And so then I understood that something great was happening. Especially the patient number 3. If I have some time to discuss
I'm sure.
This specific patient, number 3, almost as important as the first patient, because this woman was coming from Paris. She was 80 years of age. And she had been hospitalized 2 months in the best hospitals in Paris, and the cardiologist said to her, to the family, take her back home to die because we cannot do anything, it's finished. Okay. So she went back, she was in cardiogenic shock, she had a previous myocardial infarction, it was a very, very horrible case. And she was back home and she watched the TV. And on the TV, she saw the report of the first patient. And she said to her daughter, call this doctor in Rouen, and take me there because maybe he can save my life. So I took the phone, and I had her daughter on the phone, and I explained to her that it was a very desperate case, and that I was not sure that she would survive transportation between Paris and Rouen. It's 120 kilometers, but she did it, and actually the valve was implanted. She was really dying, this patient. I advised the family that the chance of success was very ridiculous. 6 months later, she was back home, perfectly normal. One year later, she was able to travel to Washington, D.C., to attend the TCT meeting, and she spoke she talked to in front of 2,000 cardiologists at the TCT meeting, and she explained what was a transcatheter valve.
Amazing.
And I think that this patient, the improvement has been so unbelievable, amazing, that she played a very important role, to convince the cardiologists that it was not a crazy technology. I had also another patient who was, for me, very important because it's the first patient who received a planned retrograde approach for TAVI because she had an associated mitral stenosis that prevented me to do the transeptal catheterization. And so I went to the ethical committee and to the French authority and said, well, we have these patients, but I cannot use the transseptal approach. If we don't do anything, she dies. So let me do it transfemorally. And they said yes. So this was the very first planned transfemoral approach, which opened the way to where we are today. And in maybe 45 minutes, the valve was implanted without any problem.
Wow.
I had developed the rapid pacing. I didn't tell you that because to get a cardiac standstill, to have a blockage of the heart at the time of implantation. And the cardiac standstill actually was developed for balloon aortic valvuloplasty, to help stabilizing the balloon. So the procedure was as simple as it is today, more or less. And this patient survived more than 5 years.
Wow.
She took all the Department of Cardiology in Morocco for some kind of family celebration. She was doing absolutely normal, and both of them, the patient number 3 and the patient number 10, this one,
10.
They died of breast cancer, so it was absolutely nothing to do with the valve.
Things.
But the valve was doing perfectly well. The first patient that I took, the one who went to Washington, survived almost 7 years. And she died of something else. And until this moment of death, the valve structure was working perfectly well. The hemodynamic was unchanged for the 2 patients. And we had the same kind of experience in the other patients. Many of them died after 1 year, 2 years of their comorbidities, but they were all improved very much at the time of the valve was implanted. So then I realized that we were at the start of a revolution in medicine, And I start thinking that if the TAVI was working in such sick patients, it would work even better in less sick patients. This was in my mind. But I could not expect to reach the situation of today.
And the rest is history, as they say.
And to finish with the transseptal thing, I received the clearance to start doing cases abroad.
Okay.
So we started training very important guys in cardiology, like, of course, Martin Leon, but John Webb and Colombo and Ceres and Bill O'Neill was the first American who implanted the valve transseptally in Detroit, in the United States, Europe. So in 2005, we had the total number of TAVI done, 100 cases done. And in their experience, they had the same kind of observation of patients tremendously improving, recovering normal life. They did that on celebrities, that appeared on a TV screen, on TV shows, in the United States. It was the improvement of patients was probably more important than the scientific result that we could provide, because this, they were the witness of what can be done with this technology.
Yeah.
So the role of the patients has been extremely important.
That's a wonderful summary and a wonderful story. And as I say, the rest is history now. We've had millions of TAVIs done over the world. Albert Einstein once said that if an idea is not absolutely crazy, there is no hope for the idea. It's hopeless. So you proved him right. So if an idea is not absurd, it's hopeless. So your idea was deemed crazy.
Yes,
and eventually with your conviction,
but
you made it work.
In general, when we do innovative technologies, because I had some other experience, I developed mitral commissurotome, I developed some devices for PCI and so on. It's always the same story. The people cannot. When you are talking about your innovation, the first reaction is always negative. Because they think if it could exist, it would already be done, And many people think if it could be done, I would be the one doing it. But this is a clear-cut human reaction. When you have an innovation, when you hear about an innovation, the first reaction is to say it will not work. So please, if you do something like this, never be discouraged and go on.
Keep going is your motto, basically, to deal with what seems like failure at the time. Thank you. I've got a few more questions for you.
Oh, yes,
so, who would you say, could you name 2 people who you think have helped mold or shape you as the Alain Cribier that we know today? Not just the cardiologist, but the human being as well. It could be two medical people, it could be one medical, non-medical,
Yes,
whichever you wish.
Actually, this is a good question because, in fact, many people have been influencing me to become what I have done
Yes.
as a human being. You know, first of all, I am coming from a very modest background.
Okay.
You know, they were not at all in medicine. You know, they were worker, my parents.
Okay.
But I had an aunt and uncle. One was a dentist, and the other one was
midwife.
Midwife, yeah, very well known in Paris.
Okay.
And so when I was a kid, you know, they put in my hands many books about medicine, and I was absolutely passionate, you know, to read these books, you know, on innovations, you know, the last centuries, you know, the big name Laennec and all. And then when I was 9-10 years of age,
okay.
I had several meetings with a very important person for me, which is Dr. Albert Schweitzer.
Okay.
And Schweitzer was a very famous guy because he was an extraordinary musician. He was an organist. He was an international renowned organist.
Okay.
This is the way he was making his money. And he was also a doctor.
Okay.
And this person, you know, opened the first hospital in Africa, in Africa,
okay.
in Gabon.
Oh, okay, wow.
And he opened the very first hospital in this part of the world, you know, in Africa, in the middle of nowhere, in the jungle, in the forest, in Gabon, in Lambaréné, the place.
Wow.
And so I was fond of admiration for him, and I met him several times because he was spending his time in France when he was in France, in the place where I was also having my summer vacation.
Okay.
So I discussed with him several times. I was sitting next to him on the organ of the Gunsbach.
And I know you're a wonderful piano player and a keen fan of Chopin.
Yes, well, actually, maybe also because of him, because he influenced me a lot. So this is the very first person that encouraged me, you know, to do medicine and well. And after that, you know, when I started my medical studies in Paris, it was in the 60s, I am afraid to say that. I had all my stays, most of my stays in cardiology department and cardiac surgery department, because I was very much interested by cardiology from my readings. And so I spent the time with cardiac surgeons like Professor Dubost, for example, who was also one of my mentors. But I have been his instrumentist in the operative room for 4 years.
Okay.
And so I discussed with him. I was absolutely fascinated. He was working on innovation in the field of cardiac surgery, so I wanted to become cardiac surgeon. You know, it was clear in my mind. And then I also went to a very important department of cardiology in Paris. Not cardiac surgery, but cardiology department. Okay. And it was at the time of the launch of the first intensive care units and the first cardiac catheterization laboratories. Okay. So I was probably one of the first still living person, you know, who have been manipulating catheters. You know, this was in 69, 70s, you know, so, and at the time the catheters were not radio-opaque, for example, just to give you an idea.
Wow. Mm-hmm.
And left catheterization has to be done transapical. You know,
Never seen that.
Well, so I had some training in this. So this was very important. And this person, and there was in one of the cardiology department a fellow who said, you should go to Rouen because there is a person there, the chief of department, who is a very bright guy who has been spending 1 year with Sones in the United States. Sones was one of the pioneers of cardiac catheterization, and he's very open to research and so on. And so this is what I did. So I got the residency in Rouen, which is 120 kilometers. It's the capital of Normandy, where Joan of Arc was burned by the British. And so I met this guy, this professor of medicine, who was the chief of department, and he was very keen of having me with him because he was opening the cath lab in Rouen, and he had to have somebody with some experience. And I was the only one, more or less, who had some experience of it. So immediately we started a kind of complicity, and it was on clinical basis, but also in research. And he was very open to innovative technology. So this is an important mentor for me, Professor Letac. And then he took the decision of sending me to Cedars-Sinai Medical Center in Los Angeles.
Where you met
without him, I won't be there. So Swan and Gans in Los Angeles have been very, very important mentors. And also, you cannot do, when you want to innovate in medicine, you cannot do anything yourself, alone. You need a team. And in Rouen, when I came back from the United States, the situation was very special because there was a real, optimal, great partnership between the interventional cardiologist and the cardiac surgeon. And this has been crucial. I didn't have... They were the only cardiac surgeons who were not against my ideas.
Wow,
so they were supporting. And because of them and the partnership with the cardiology department, we could innovate in different fields, and especially in the valve.
You had that freedom as well.
Yes. So you need a team, and the team was a dream team. For example, in interventional cardiology, all the nurses, technicians, the doctors, they were very, very supportive, and they were encouraging me, because there were some phases where I showed some kind of sadness, and I was a little sorry of not succeeding as fast as I wanted, and so on. They were always behind me, and this has been absolutely crucial.
Important.
So these people have been very, very crucial. And the last people that I met were really decisive meetings, with the people from Johnson & Johnson that I introduced to you.
Fantastic. Thank you for sharing that.
Yeah.
Not many people know you have a very special bond with India. You actually you set up the Indo-French Foundation of Interventional Cardiology. Could you share perhaps with us your first experience of visiting India, I think now many years ago, and how did you find it? What attracts you to India?
You want to talk about India?
Yeah.
India, yes, is my second country. Yeah,
second home.
Country. Yes, actually, I started going to India when I developed balloon aortic valvuloplasty because I was called to India to teach the people and to speak about balloon aortic valvuloplasty. And I fell in love with India, really. These are the right words, and with the people and with the country. So I was absolutely amazed. I have been everywhere in India, in all the departments, and I started, being proctoring not only balloon aortic valvuloplasty in India, but anything else, all the PCI and all the techniques that were applied for coronary disease, structural heart disease, and so on. And this lasted, it is not finished actually, but I have been so often in India that it was a little ridiculous. And so
Is it true that you took a bus the first time you traveled there?
Yes, I traveled.
There was a story
before. No,
yes.
Actually, to tell you the truth, I did my first travel in India in '69.
Yes.
In '69, it was for vacation, but I wanted to discover this country because at that time, in '68, it was big revolution in France. The May '68, and everyone wanted to go to India. I don't know why, so I followed the crowd, and I went to India, and I made a round trip in India. And I spent several weeks in Pondicherry, and where I was able to go to the department of cardiology there that they had, and so I was fascinated by all this pathology that they have because this is kind of pathology we didn't have in Europe. So many rheumatic disease and so on. And so when I came back from my first visit to India, one of my ideas was to say, I would like to help these people, to try to do something for them.
Yeah.
Then I had my wedding trip in India with
Oh,
my wife.
wow.
And so in it, then there was a gap, and I think I went for the first time to work in India in '87.
Okay.
For ballon-aortic valvuloplasty,
Okay.
and then this proctoring program all over the places, for all interventional cardiology started and during many years, and 3-4 years later we created with Indian cardiologists a foundation that we call the Foundation of Indo-French Foundation for Interventional Cardiology, and we started a fantastic program of exchange. We received in Rouen more than 500 Indian cardiologists who were coming to Rouen like part of their training program, And I was myself organizing meeting, Indo-French meeting once a year, and I brought to India all the cardiologists of France. All my friends, cardiologists in France, went to India for the Indo-French meetings. So it was a very special relationship. And after that, when I started working on the valve, I couldn't travel so much in India. And then now I am coming back to India, and for my great pleasure, to speak about TAVI and to proctor or to discuss about TAVI with these people in the meetings. And so it's starting again. And actually, it's funny because I never lost the contact with the Indian cardiologists. They are not superficial people. When they love you, they love you. So we maintain a relationship which was absolutely extraordinary over time. And today, when I am invited in Department of Cardiology, very often these people who are leading their place are previous fellows who come to Rouen for training. All the one, so it's a kind of...
It's a big family. It sounds
family.
like
It's a second family.
It's wonderful.
Yeah. So this is my story with India, which is very strong, actually. Yeah.
Great to hear that. My next question to you is, so now looking a little bit more towards the future, artificial intelligence has seen a huge expansion in the last few years. AI. In healthcare, it's got multiple applications. So in radiology, it's been shown that machine learning can process really huge, vast amounts of data in a minimum time frame. There's been robotic surgery, for instance. There's been ChatGPT, which has been a lot in the debate, in the conversation lately, so ChatGPT can pretty much answer any scientific question that you ask it. I can't guarantee the accuracy or the reliability of the data because I don't know much about ChatGPT, but it's there. Do you think that there will be a role for AI in TAVI, for instance? I was thinking maybe in procedural planning. Could it be that one day we see that the machine interprets, the person's age, BMI, risk factors, ethnicity, and then comes up with, this is the valve that you should be putting in? Do you think we'll...
Yeah, I will answer these questions of artificial intelligence. Just before, if you don't mind, I just would like to not to skip the following period after the initial period of TAVI, which has been lasting 20 years of evolution and improvement of this technology, with this number of advanced technologies that have been developed, and also all the scientific evaluation, which has been extremely important, starting from the worst patients, moving to the
lower risk
patients. The history of these 20 years have been extraordinary. And I could observe, I was fascinated to observe the number of patients, implanted increasingly everywhere in the world. It was an exponential curve, and also I would like just to say that I am very proud that with Elena Tcherninov, who is just coming here, we were able to develop the minimalist strategy for TAVI that is applied today. And we had the first publication on that. And because of our efforts, to do it very simply, percutaneously, without any transesophageal echo online during the procedure, making the procedure very simple, and shortening the hospitalization stay and so on. the minimalist approach, which has been very much criticized, and especially in the United States and UK, because they said that it was unethical, But when I see that today, all the procedures are done like we implant a stent.
Yeah.
Today you can implant a valve in 30 minutes, and the patient is back home totally treated in a very good shape in 2 days. So this is absolutely fascinating.
Mm-hmm.
So now, of course, you were talking about artificial intelligence, AI. I am observing this with kind of fascination because there is absolutely no doubt that using AI would help, for example, for interpreting the imaging, of the MSCT, and without hesitation, and this technology would be able to say, this is a kind of valve that you can implant because you don't want to cover the coronary arteries. The things that we are doing today, but very often with some discussion. So if you put in the memories of AI all the data in the world, they will be able to help you in the decision. But I am not really fascinated, by this technology in medicine, because in fact, for me, the relationship of the physician with the patient is much more important, and you have many aspects that cannot be introduced in the AI system. That is the personality of the patient, the family environment, the physical aspect of the patient, anything, and also the confidence that the patient has for you, and the exchange. And this is something that is very human. It's the human relationship that you can establish with the patient is probably more important than knowing that you must absolutely implant this model of valve with this size of valve. It can be helpful, and but I don't think that it should summarize, the process of patient screening. I mostly believe in the relationship with the patient.
I love what you just said. Really. It's really wonderful.
We are not mechanisms,
we're not machines, we're treating hearts as well. So maybe machine learning, there's a role to add to what we're doing, but at the end of the day, it's a one-to-one connect with the patient.
Yes, absolutely. But we cannot follow the conclusion of the machine, as if we are not doctors. And,
absolutely.
We have to think about it twice, and we have to discuss with the patient. It's a kind of history, which is very more complex, much more complex than just having basic data.
Numbers
So I think that it can be helpful, but it should not summarize, the work that we are doing.
The next one is a slightly sensitive question. You may have heard recently on Twitter, there was a case where it was said that an advanced nurse practitioner, so an allied health professional, had been the first operator implanting a TAVI. I just wanted to know, if you don't mind, what are your thoughts regarding this? Do you...
Well, I read the story as well, so I know that, I have a trend, to give a lot of responsibility to the people working with us, not only doctors. But actually, I think, the plumber, if he knows how to push a catheter, would be able also to implant valve. It's not a problem. The problem is that when you do a TAVI procedures, many things can happen, and of course, a nurse can do it, and especially if on her side there is an experienced operator, for example. But alone, it seems to me a little too much. I won't really push people to do this kind of experience, even though I have a lot of respect for the nurses, but they don't have the training, they don't have the experience. And when you are doing an interventional procedures like this one, many things can happen from 1 minute to another. And so, this is a responsibility of the doctors, to decide if yes or not they will leave the nurses doing cases like this. I don't think so. I don't think so. But and again, I have a lot of respects for the nurses and the technicians, and but they have to stay as far as possible in their world and of competence. Today there is a big question about the fact that TAVI could be performed in a hospital without cardiac surgery on board. And there is another question. The surgeons want to do the procedure themselves. They are not interventional cardiologists. They want to do the TAVI themselves.
This is in France?
Everywhere in the world. The surgeons are very interested by the success of TAVI, and they are very much concerned about the becoming of cardiac surgery. So there is a trend, to see the surgeons asking to do TAVI on their side, themselves. And so this is a big discussion, and they are cardiac surgeons. So now we are talking of nurses, so nurses, they don't have this kind of training. So the surgeons, if they are very well trained, we can imagine that with the possibility of having an interventional cardiologist with them, they can do cases as well. So I have nothing against it.
Okay.
So this is another story.
Okay. What is the next unmet clinical need in medicine or in cardiology? Where do you think we're going?
Many clinical needs, that I don't even know myself, in other specialties, not only in cardiology. I think that in cardiology, the possibility of treating heart failure, on chronic basis, with circulatory assistance, more smaller and smaller with inside the body and so on. This is something that could really improve the patient's life. Many works are done, to treat other valve and the structural heart disease with interventional techniques, and so there are some needs there. Maybe less than expected by many. For example, the treatment of functional mitral insufficiency, is not, for me, absolutely clinical need, really, because you are not treating the disease, you are treating the symptoms. And even if you improve the patients for a short period of time, the patients will die of the basic disease, which is responsible for the functional mitral insufficiency, and it's the same for many things. So, there are many needs, I think one of the most important clinical need would be the prevention of the disease. Also, we are treating the disease. We are not so much interested by preventing the disease. So this is why in Rouen, for example, we have a huge research program. It's a national program that we call RHU, which is also headed by LL Chaninov, where we collected a large amount of money from the French government and also from the companies, to try to find out the cause of in particular. Not only that, but finding the cause of aortic stenosis might lead to preventing aortic stenosis in the future, thus destroying TAVI. Which would be.
How do you feel about that?
No, I think we are probably not enough concerned about prevention.
Okay. You've achieved a lot in life. You're somebody that I admire very much, yet you remain very grounded, very humble, approachable, and helpful. What keeps you so humble? Because
this is your opinion. Yeah.
I think a lot of people would agree with me.
This is your opinion. No, but there is no reason not to be humble, because actually, as I said at the beginning of this discussion, when you do something like this, you are not alone. So it's not me who did that. It's a team. It's a number of people who have been working, the engineers. It has been a fantastic translational research pathway. And so I don't have any good reason to be very proud of myself, because I really believe that without the others, I won't have been able to do that. So I am a regular cardiologist, interventional cardiologist, who had some ideas. I had the opportunities of developing it because I had also, as I said, the chance on my side many times. And that's it.
It's a bit of chance, a bit of conviction, and a lot of hard work. So it is a known fact that women are quite severely underrepresented still in interventional cardiology and in TAVI. You yourself have had a key role in mentoring and in molding the the careers of numerous female fellows that I've had the pleasure to meet. You also enjoy a very beautiful working equation with Professor Hélène Elchaninov, with whom you've worked very closely. Why do you think it's important to have more women in the specialty?
I think the women are have a different brain than the men, you know, and they are not trying always to demonstrate that they are the best in the world, and they don't have that big ego. And I think in interventional cardiology, the women are very, very good. Very good, because they keep their calm, you know, they are not trying things, you know, to prove that they can make it, you know, they are just following the rules very strictly.
Yeah.
And I have been always very much amazed by the results obtained, and also the behavior of the women with the patients, you know, it's a little different. And I think interventional cardiology really needs women. I really realized that at the very beginning of my career, because I have been really supporting women in my department when I was chief of department. Actually, there is a misogyny, you know, in the misogyne aspect of the problem. You know, when I asked China, for example, she was a resident, when I said, if you want to do the cardiac catheterization, you can. You know, I was very much criticized for that, because she was a woman.
Really? By your colleagues or by?
Yes, by my male colleagues. So it was not that easy, you know, to and after that, you know, when the women demonstrate that they are excellent, you know, and especially, you know, keeping the calm in the worst circumstances, you know, and not trying to demonstrate that you are the best in the world all the time. This is an important aspect of a woman, and I love to see women doing interventional cardiology and implanting valves.
I'm so glad you said that, because a lot of times young trainees, female trainees hear, oh, women are too emotional to be doing this.
No, they are not emotional. They are not emotional. They keep their calm, you know.
I agree with you.
Yeah.
Thank you so much.
No, it's my pleasure.
My last question to you, sir. For people watching you, young cardiologists who want to embark on TAVI or who want to embark on a new innovation, what are your final words for them, your advice in life?
You know, just say the cardiologists who want to start TAVI. Yeah. They have to follow the rules. You know, first of all, they have to get perfect training in PCI and in general interventional cardiology.
Yes.
And then they move to TAVI, and so they have to follow the rules, which consist in having a training program, following a training program. So each company is making valves today, and many companies are making valves, are organizing specific training programs before giving you the certificate that you can implant valves. You know, so it includes work on simulators, you know, entering into cath labs or seeing live cases, you know, any kind of things. And after that, these people, you know, they have to be followed by proctor during a few days, you know, just to make sure that they know exactly moving from the theory to the practice is not that easy sometimes. And after that, it may not be finished. And this is why, you know, I strongly believe that these young operators, or the people who want to start, they should follow some additional training programs in order to answer their main issues about the technique that they don't have in their hands, you know, immediately.
Yeah.
And so many places are organizing additional training programs that you can repeat every 2 years, every 3 years if you want. And for example, in Rouen, as you know, we are organizing this kind of program twice a year. And we are receiving people from all over the world. And these people are, in general, young cardiologists or people who have already an experience of TAVI, but who are not very satisfied by their practice. So they want to get some confirmation. And so we are doing live cases. We are taking them in the cath lab at the same time, you know, it's a small group of people, not more than 30 people, because if not, it turns into a congress. It's not a training program. So we let them work with the simulators of all the valves existing. And also we are showing them the practice of TAVI in real life. in different parts of the world. So we are transmitting live cases for many countries, you know, from Asia, from Saudi, from the United States, from Europe. And at the end of 3 days like this, you know, where they have been also trained on CT simulators, which is also an important part for the screening of patients. They feel very much comfortable. Okay. And very often they ask to come again, you know, because to maintain a level, you know, and to follow the progress, because also things are changing so fast, you know, new devices, new...
It's wonderful. So we've reached the end of the podcast. I have been lapping up all these pearls of wisdom. I wish we had longer, but there are time constraints, which I understand. I thank you again for warmly welcoming me within the team. I hope you know what kind of impact you've had on not just me, but a lot of young cardiologists starting their career, starting their journey.
Ask them to come.
I will definitely. And I do hope that I hear your name on the next Nobel Prize list.
Well, it's another story.
Thank you, sir.
Thank you very much. Thank you, Jemina. Thank you very much.